We've spent this entire series talking about how cells respond to stress. They adapt, they die, they trigger inflammation, they heal. In every one of those scenarios, the cells were still playing by the rules. They were still responding to signals, still dying when they were supposed to, still limiting their own growth. Today, we talk about what happens when cells stop playing by the rules entirely. Neoplasia, cancer, is the consequence of cells that have acquired the ability to grow without permission, resist death, invade neighboring tissue, and spread to distant sites. It's one of the most important topics in all of veterinary medicine, and everything we've covered in this series has been building toward it. The definition of a neoplasm that has stood the test of time was written by Rupert Willis in 1948. An abnormal mass of tissue whose growth is uncoordinated with that of normal tissues and persists in the same excessive manner after the cessation of the stimuli which evoked the change. Let me unpack that for you. Uncoordinated means the growth is not responding to the body's normal regulatory signals. Exceeds and persists beyond the stimulus means if you remove whatever triggered the growth, it keeps going anyway, unlike hyperplasia, which regresses when the hormonal signal is removed. This persistence is the biological hallmark of neoplasia, and it reflects permanent genetic changes in the cells themselves. The most important clinical distinction in oncology is benign versus malignant. These terms have very precise meanings in pathology, and I want you to be clear on each feature. Benign tumors grow slowly, push rather than invade, stay encapsulated, look like their tissue of origin, and, critically, never metastasize. They can still cause serious disease by compressing vital structures, but they will not spread. Malignant tumors, cancers, invade locally, may spread to distant sites, grow more rapidly, show greater cellular abnormality, and can be life-threatening through multiple mechanisms. The single feature that definitively establishes malignancy is metastasis, finding tumor cells at a site distant from the primary. But we use all of those features together to predict the likelihood of metastasis before it happens. Tumor nomenclature is actually a logical system, not a list to memorize. Every tumor name tells you two things: what tissue it came from and whether it's benign or malignant. The suffix "oma" generally means benign: fibroma, adenoma, lipoma. The suffix carcinoma means a malignant tumor of epithelial origin. The tissue lining surfaces and glands. The suffix sarcoma means a malignant tumor of mesenchymal origin, connective tissue, bone, muscle, vessels. So an osteosarcoma is a malignant tumor of bone cells. An adenocarcinoma is a malignant tumor of glandular epithelium. There are exceptions. Melanoma sounds benign, but it's often malignant. Lymphoma sounds benign, but it's always malignant by definition. But the core rule, carcinoma for epithelial, sarcoma for mesenchymal, will carry you through most of veterinary oncology. In 2000, Hanahan and Weinberg published a landmark paper describing the hallmarks of cancer, the set of biological capabilities that cancer cells must acquire to become fully malignant. This framework is revolutionary because it shifts thinking from what gene is mutated to what capability has the cell gained. Normal cells need external growth signals to divide. Cancer cells generate their own. Normal cells stop dividing when they receive anti-growth signals. Cancer cells ignore them. Normal cells commit apoptosis when they're damaged. Cancer cells evade it. Normal cells can only divide a finite number of times. Cancer cells find ways to maintain their telomeres and divide indefinitely. And then cancer cells recruit blood vessels to feed the growing tumor, break through tissue barriers to invade locally, spread to distant sites, shift their metabolism to support rapid growth, and hide from or actively suppress the immune system. Each of these is a targetable vulnerability. It requires specific types of genetic damage, and understanding the two categories of cancer genes makes this much more intuitive. Think of a cell as a car. Proto-oncogenes are the accelerator. They promote cell division when growth is needed. A mutation that gets the accelerator stuck in the on position creates an oncogene. These mutations are dominant. Even one mutated copy of the gene overrides the normal copy and drives uncontrolled growth. Tumor suppressor genes are the brakes. Their job is to slow or stop cell division. When both copies of a tumor suppressor gene are lost, the two-hit hypothesis, the brakes fail entirely. P53 is the most important tumor suppressor in biology. It's mutated in roughly half of all cancers in animals and humans alike. It acts as a cell's guardian, triggering apoptosis or cell cycle arrest when DNA damage is detected. Lose P53 and damaged cells that should die instead survive and accumulate more mutations. How does a tumor actually invade surrounding tissue? It's not passive, it's an active multi-step process. First, tumor cells lose their grip on each other. Normal epithelial cells are held tightly together by adhesion molecules, particular E-cadherin. Many cancers downregulate E-cadherin and the cells start to separate. Some epithelial tumor cells undergo a dramatic transformation called the epithelial mesenchymal transmission. They essentially reprogram themselves to behave like mesenchymal cells, elongated, motile, invasive. Then they secrete matrix metalloproteinases, enzymes that are basically molecular scissors for connective tissue. These MMPs digest the basement membrane, the critical barrier between epithelium and underlying stroma. The cells migrate through this degraded matrix following chemical gradients, and as they invade, they remodel the surrounding stroma, recruiting fibroblasts that lay down dense collagen, desmoplasia, which is why many carcinomas feel rock hard on palpation. Metastasis is what makes cancer lethal in most cases. So understanding the steps matters enormously. The cascade has 6 major steps, and here's something counterintuitive. The vast majority of circulating tumor cells fail to complete it. Studies suggest only 1 in 10,000 or even 1 in a million circulating tumor cells successfully establishes a metastatic colony. Tumor cells in the bloodstream face immune attack by natural killer cells, mechanical shear stress, and a process called anoikis, programmed death triggered by loss of attachment to a matrix. So metastasis is biologically inefficient. But the sheer number of cells a large tumor sheds into the circulation every day means that even a tiny success rate produces clinically significant metastasis. The two main routes matter for prediction. Carcinomas tend to spread first via lymphatics to regional lymph nodes. Sarcomas tend to spread hematogenously, and the lung is the most common first site, which is why chest radiographs are part of every sarcoma staging workup. Grading and staging are 2 separate assessments that answer different questions, and confusing them is a common student mistake. Grading is done by the pathologist looking at the tumor cells under the microscope. How much do they still resemble their tissue of origin? How many mitotic figures are present? How variable are the nuclei? A well-differentiated grade 1 tumor still looks a lot like normal tissue. A poorly differentiated grade 3 tumor may be so abnormal that you can barely tell what tissue it came from. Grade predicts biological behavior. Staging is the clinician's job. How far has this tumor spread? The TNM system is universal. T for primary tumor size, N for regional lymph node involvement, M for distant metastasis. A stage 1 patient has a localized tumor with no spread. Stage 4 means distant metastasis is present. Staging drives treatment decisions and prognosis more than any other single factor. The most clinically important and often underappreciated aspects of neoplasia is the paraneoplastic syndrome. Tumors don't just cause problems by taking up space, they can produce hormones, hormone-like substances, cytokines, and antibodies that cause systemic effects completely unrelated to the tumor's physical location. We already discussed hypercalcemia of malignancy when we covered pigments and calcification. That's a perfect paraneoplastic example. The anal sac adenocarcinoma is sitting in the perineum, but it's causing kidney damage through elevated serum calcium via PTHrP. An insulinoma in the pancreas causes hypoglycemia, not because it's blocking anything, but because it's producing excess insulin. Cancer cachexia, the wasting and muscle loss seen in many cancer patients, is driven by cytokines like IL-6 and TNF-alpha that completely reprogram metabolism. Sometimes the paraneoplastic syndrome is the presenting complaint that leads to the cancer diagnosis. Concepts to close out this series. Neoplasia is where everything we've covered comes together. Cell injury and mutation drive the initial genetic changes. Cells that would normally undergo apoptosis escape it. Adaptation mechanisms get hijacked. Growth signals that normally regulate hypertrophy are permanently activated. Inflammation in the tumor microenvironment, chronic macrophage-driven, actually promotes tumor growth and angiogenesis. Repair mechanisms are co-opted to build the tumor stroma. And the accumulations we covered, hypercalcemia, metabolic byproducts, often signal the tumor's systemic reach. Pathology is not a collection of isolated topics. It is one integrated story about how cells respond to a world that constantly challenges them, and what happens when those responses succeed, fail, or go terribly wrong. You now have the framework to read that story. Video, read the scenario, give it a try, and we'll work through it together. This tumor is malignant, and the reasoning is straightforward. It is metastasized. The presence of a second mass in a distant lymph node is the defining feature of malignancy, regardless of how benign the cells look on cytology. This is a critical teaching point. A well-differentiated cytologically bland tumor can still be malignant if it demonstrates metastatic spread. Conversely, a cytologically alarming looking tumor with marked pleomorphism may behave relatively benignly if it doesn't invade or metastasize. In practice, well-differentiated splenic tumors that metastasize to lymph nodes in older golden retrievers should raise concern for splenic marginal zone lymphoma, a relatively indolent but definitely malignant lymphoproliferative disease. The metastatic event, not the cell morphology alone, establishes the diagnosis of malignancy.